Hello, and welcome to today's webinar, Management of Tracheostomies, a Successful Journey to a New Prevention Protocol. This webinar is part of the WoundSource Wound Care Product Navigator Series. The Wound Care Product Navigator Series is an easy-to-access interactive learning lab for healthcare professionals to get the latest information they need on the wound care products available to them. Each webinar segment will take a deep dive into a specific product technology. This program will look at the importance of tracheostomy management and explore strategies to control moisture around tracheostomy sites. Our sponsor for this installment is Ergo Medical. My name is Amy McCauley from WoundSource, and before we get started with today's webinar, I just want to go over a few details. As a reminder, Kestrel Health information does not give medical or reimbursement advice, nor do we provide medical or diagnostic services. The content of today's webinar is for informational purposes only. The views and opinions expressed in this webinar and contents are solely those of the presenters and do not represent the views of WoundSource, Kestrel Health Information, its affiliates, or subsidiary companies. Now I want to take a moment and provide you with an overview of your webinar console. At the bottom of your console are application tools that you can use during the webinar. To submit a question to our guest speaker, please select the Q&A app icon on your screen and type your question in the field provided and select Submit. We will try to answer all of your questions during the question and answer period. You can expand your slide area by clicking on the Maximize icon on the top right of the slide area or by dragging the bottom right corner of the slide area. Our sponsor has included additional information on today's products. On the right of your console, you will find a list of resources available for download. This webinar is being recorded and will be made available on demand. If you have any other requests or questions pertaining to this program, please contact our sponsor using the Contact Us app located in the tray of your console. At this point, I want to welcome our featured speaker, Daphne Hodges. Daphne is a certified wound, ostomy, and continence nurse with 19 years of nursing experience in multiple clinical settings. Daphne, thank you so much for joining us today.
Thank you, and good morning. My name is Daphne Hodges, and I'm a certified wound, ostomy, and continence nurse working in a small coastal community about 70 miles north of LA and 30 miles south of Santa Barbara. I work full-time at Community Memorial Hospital, which is a small health system made of a community-based teaching hospital of about 250 beds, a small critical access hospital, a skilled nursing facility attached with a rehab facility, and we have a bunch of community health clinics across Ventura and our neighboring towns. This morning, I have a couple of disclosures. I am a speaker and consultant for 3M KCI, as well as Ergo Medical. So pressures are a hot topic when it comes to looking at nurse quality indicators. As a healthcare clinician, this is definitely something that I pay attention to, especially with the specialty of wound care. Pressure injuries are considered a never event by CMS, the Joint Commission, the National Quality Forum, and the Agency for Healthcare Research and Quality. Never events are serious and they are costly, and so they should never happen. And according to the National Quality Forum, never events are errors in medical care that are clearly identifiable, preventable, and serious, and they have great consequences for our patients. And so therefore, it becomes really top priority, and it is so in my hospital. So what is a pressure injury? The NPIAP defines it as localized damage to skin and underlying soft tissue, usually over a bony prominence and related to a medical or other device. And for those of you who are unfamiliar, pressure injuries are a result of intense or prolonged pressure, or pressure in combination with friction and shear. Tissue tolerance is affected by microclimate, nutrition, perfusion, comorbidities, and existing conditions of the surrounding soft tissue. So medical device-related pressure injuries are definitely part of our daily discussion when we're talking about pressure injuries. However, it is not considered a stage within the NPIAP's defined staging system, but it does describe the etiology of the existing pressure injury. These particular pressure injuries usually take the shape of the associated device that lies over the soft tissue or skin, And depending on the location and depth of the medical device-related pressure injury, it should be stage appropriate to the NPIAP's defined staging system. So it was in 2018 that the NPIAP actually brought focus on pressure injuries caused by medical devices. And as a result, the Joint Commission, the NDNQI, and CMS are now incorporating that as part of their practice, or our practice. And so medical device-related pressure injuries should be what everybody is talking about. And as clinicians, we should be able to identify medical devices that are most likely to cause pressure injuries and provide those interventions to help prevent tissue loss and skin breakdown. So let's take a look at some of the numbers to support the issue. Van Gilder and her colleagues studied patients over a 3-year period, and they discovered that in a sample of about 87,000 patients, close to 18,000 of them had medical device-related pressure injuries. 785 of them were facility acquired, and while this was an earlier study, when medical device-related pressure injuries weren't quite as widely discussed as now, a decade later, it does show that there was some interest back in 2009. In 2010, Dr. Black and her colleagues studied 2,079 acute care patients at the University of Nebraska Medical Center who were free of pressure injuries on admission. 113 of them developed pressure injuries, and 34.5% of those developed pressure injuries related to medical devices. Kaesner and her colleagues in 2018 found that 75% of all medical device-related pressure injuries are facility-acquired, and that they are more likely to form 3 days later than non-device-related pressure injuries. This means that medical devices should be one of those areas of focus on our priority list when it comes to pressure injury prevention. So for years here at my hospital, I've received a great number of consults to evaluate and manage the wounds around tracheostomies. Trachs were typically managed by respiratory therapists and critical care nurses, and while I usually dealt with the aftermath of the problem, I was never really involved with the day-to-day management. So as we received more and more consults for these tracheostomy wounds, we would occasionally offer up suggestions to change practice in one way or another. And again, remember, it was never really something that we were responsible for, but that really the surgeons, the respiratory therapists really owned that and felt that that was something that they were the experts on. But nonetheless, we would kind of pipe in, provide some suggestions as to how to manage what we were dealing with at that moment, and there would always be some short-term improvements, and then we would be back to square one. So about 2 years ago, I finally decided that I wanted to tackle this issue to see if I could make a lasting impact. In looking at all the past cases I had been involved with, I had to identify the challenges surrounding these tracheostomies. Why were we seeing pressure injuries around tracheostomies when we had solutions, or so-called solutions? Well, one, the development of pressure injuries around our tracheostomies happened fast. Our surgeons sutured these tracheostomy faceplates in 4 spots to help immobilize the device, and I'm sure a lot of you have seen that. It is very commonplace when it comes to tracheostomies. And 2, our patients had a lot of secretions or drainage at the surgical site that inevitably seeped underneath the tracheostomy faceplate. And as all you know, there are many factors that contribute to pressure injury development, and moisture is a huge factor in this particular case. The combination of tight sutures, postoperative swelling, and secretions really create the best case scenario for a pressure injury. So I took a look at our current management. We had 2 different dressings that we used at our facility, and there was really no rhyme or reason why one person would pick one versus the other. We had a non-woven drain gauze and we had a hydrophilic foam. Both of these required 2 to 6 dressing changes per day on average. And no matter which dressing was used and no matter how frequently these dressings were changed, the skin beneath the tracheostomy was always wet and erythematous. And if they hadn't already developed pressure injuries by the time I snuck a peek, I knew that I'd be hearing about it soon enough. So non-woven drain gauzes, very, very common product and it's widely used. It's been around for a really long time, and it's meant to absorb drainage around the exit site of a drain. It doesn't cost very much at all. I believe it actually costs just pennies each layer. They're typically made of cotton, polyester, rayon, or a blend of these materials. The problem with this particular dressing is that it has a capacity to only absorb a very, very small amount of fluid. And so clinicians are having to change these out on average about 4 to 6 times a day in an attempt to keep it dry. Hydrophilic foams are designed to absorb moderate amounts of drainage. And I like hydrophilic foams. I use it a lot in advanced wound care. I like it because it helps to maintain moist wound environments. They absorb fluids and it basically holds that fluid in place to prevent the wounds from drying out. And it's great for the vast majority of wounds that I manage. However, in this particular case, when we're placing it around a tracheostomy, it does exactly that. It absorbs the fluid and holds it there, and it maintains that moist wound environment. And that truly is not the optimal place or environment for pressure injury prevention. In fact, it provides the best environment for pressure injury development. And as well, it also contributes to the perfect environment for infection. So we look forward. I basically figured that I needed to find something that would adequately manage the moisture. Whatever it was, I needed it to pull the unwanted and undesirable fluid away from the source. And in looking at some of the dressings I've used in the past, I decided that I was going to try and take a different route. I needed to try something different. So prior to embarking on this endeavor, my colleague and I had to identify our stakeholders. I decided that if it was going to be a successful program or a successful intervention, that we had to make sure that everyone involved knew exactly what we were about to do, and we needed to get their buy-in. We had to make sure that they understood what the problem was, what we proposed to do to tackle the issue, and what our expected outcomes would be. So the first person we had to talk to was our cardiothoracic surgeon, only because the cardiothoracic surgeon in our facility was the primary person who actually created the most tracheostomies. Then we had to involve respiratory therapy. This is their domain. And so we kind of talked to them about some of our issues as they have observed as well. But we had to make sure that they understood that we weren't coming in to stomp on their ground, but to help and assist to make sure that we had a good plan to manage these and ultimately help our patients. And then we had to involve our critical care nurses. Again, this is part of their daily practice. We were coming in and changing things around for them. So we wanted to show them that we could potentially improve outcomes and hopefully change their practice in a way that benefited the patient and them as well. Once everyone understood the issue, we then proposed a trial with a hydroconductive dressing. And we essentially set out to determine whether or not we could prevent pressure injuries. I was first introduced to Dratex through a former colleague of mine, and she told me about this dressing that would handle drainage like no other. It was probably about 2 years later that I found myself holding this dressing that I learned about at a conference that was the same dressing that my former colleague of mine had handed to me. My local rep brought me samples of Dratex rope, 4x4s, and the tracheostomy and tube dressing. Within a week, I was challenged with the most awesome wound that drained copious amounts of caustic fluid, causing significant chemical irritation and erosion of the skin. So I decided to pull that Dratex out and put it to the test, and rigged the most amazing dressing setup that eventually wicked that fluid up and away from the skin. And within minutes, you could see Dratex moving that fluid from one space to another. The skin adjacent to that wound had healed rather quickly, and from that point, I knew that dressing was that dressing that everyone should be reaching for that could handle the drainage like no other. Dratex tracheostomy and tube dressing became the subject of conversation when I was finally faced with the challenge of handling fluid and moisture around tracheostomies. So let's look at the mechanism and the technology in Dratex, a hydroconductive dressing. First, there's capillary action. It has the capability of drawing thick secretions up and away from the wound. When used around the tracheostomy, the wound fluid and secretions literally moved from the underside of the dressing to the top, which also describes the hydroconductive action. The dressing pulls fluid vertically and horizontally through the dressing while leaving the skin underneath dry and intact. Lastly, Dratex has an electrostatic action. It draws out wound exudate, secretions, devitalized tissue, bacteria, and harmful chemical particulates. Dratex is an active dressing. It has the ability to physically transport and move exudate away from tissue and exit sites such as wounds, tracheostomies, peg tubes, etc. This exudate oftentimes carries bacteria, debris, necrotic tissue, biofilm particulates, and MMPs full of inflammatory cytokines and harmful proteases. So the trial of Dratex tracheostomy and tube dressing around our tracheostomies was, I felt, a rather simple process. We proposed that the dressing be applied in the OR at the time of tracheostomy creation. And then we set out to observe our patients and the dressings to see how they would perform. And all of our patients were observed for the duration of the hospital stay from the time that they received the tracheostomy, and then we reevaluated the patient every 1 to 2 days with the exception of the weekends, and that's when we had the respiratory therapist follow up. We didn't at the time want to prescribe a frequency of dressing change because we weren't quite sure how the tracheostomy dressing would actually function around new tracheostomies. And so that's why we had the every 1 to 2 day evaluation, just to be able to understand what we were going to expect in the future. So this is our first patient who had the pleasure of receiving this Dratex tracheostomy dressing at the time of tracheostomy surgery. Prior to the surgery, I had asked the surgeon to actually suture right through that dressing so that we could have it secured in place. However, suturing the dressing to the patient proved to make removal challenging. And as I attempted to cut the dressing away post-operatively, I inadvertently cut the sutures, which thankfully didn't cause any harm to the patient, but nonetheless, we learned from that. Subsequent dressing applications were done by placing a couple of cuts through the dressing to accommodate sutures for easy removal, and you will see that on a later slide. The photo on the left is actually post-op day 5, and as you can see, the sutures were placed through the dressing intraoperatively, and at post-op day 5, it's only about 80% soiled. The photo on the right is actually what the soiled dressing looks like underneath. And as you can see, the skin remains dry and intact. There were no signs of redness or skin erosion from the moisture. Patient 3 is a patient that my colleague Isabel Jimenez had actually managed. This particular patient was 72-year-old. She was diagnosed with high B-cell lymphoma, stage 3, in November of 2019. On December 21st, she came to the emergency department for difficulty swallowing. She had voice hoarseness and shortness of breath. And she had her first round of chemotherapy actually just a few days prior to her tracheostomy. On Friday, the 18th, she had an emergent tracheostomy placed by the on-call ENT who had not been aware of the dressing evaluation, nor had he been trained on the dressing. On the 21st, a few days later, Isabel assessed the patient and noticed that the tracheostomy ties were tight, and Draw-Tex was applied with the assistance of a respiratory therapist to offload the trach flanges. On the night of the 21st, that same night, the tracheostomy was decannulated and had to be exchanged for a longer tracheostomy. On the 23rd, just a couple days later, the patient was discovered to have developed a hospital-acquired device-related stage 3 pressure injury secondary to the tracheostomy. And that was because the Draw-Tex was actually not placed underneath that tracheostomy. The tracheostomy was so tight that even a split gauze wouldn't fit. The ENT was contacted and sutures were removed at that time. Draw-Tex was applied and exchanged once every 3 to 4 days for a week due to drainage. And once that drainage decreased, Draw-Tex was exchanged weekly. And after the placement of Draw-Tex, the pressure injury came close to complete resolution within 3 weeks. And unfortunately, we couldn't actually have a complete follow-up just because the patient at that point had been transferred to a skilled nursing facility. I wish I had something significant to say. I didn't have, not that we had a negative outcome for this particular patient. But essentially what I'm showing here with patient 5 is just how the patient came out of surgery. So these pictures were taken post-op day 1. And as you can see, there are additional cuts on either side of the tracheostomy faceplate, aside from the manufacturer's vertical cut at the center of that dressing. But as you can see, that aside from the strike through that you can somewhat see on the photo on the left, you can see on the right side that the dressing has kept the skin beneath it clean and dry. You can see the vertical wicking action and the horizontal wicking as well on the right. And as saturated as that appears, again, the skin looks pretty dry. So this is our 6th patient. The first row we have our post-op day 2. And what I'm trying to show here basically is that on day 2, the dressing was about 50% soiled. And underneath the dressing, the second photo shows that the skin underneath is dry and intact. And when we removed the dressing, photo 3, you can see that the sutures remain intact. They were undisturbed as we removed that dressing. And so we knew that it helped to maintain the immobilization sutures. The fourth picture shows that we cut a new dressing and we were able to secure that dressing underneath, accommodate the sutures, and have a very effective application of that dressing. The second row is our post-op day 7. Over here at our facility, we removed the tracheostomy sutures on the 7th day, and that's when we naturally had our next dressing change. So on post-op day 7, the dressing was about 80% soiled. The sutures were removed. You can kind of see in the photo, the second photo, that we have that much soilage, but in the third photo, after removal, you can see that the skin still appears clean, dry, and intact. And again, the final final photo shows a successful application of this Draw-Tex dressing. Patient 7 had his tracheostomy placed at an outside facility with Zeroform gauze around the tracheostomy site. So that's not typically our practice here. However, he arrived at our facility with the Zeroform still in place, and that was post-op day 6. The tracheostomy sutures were still in place, and so we didn't actually remove the sutures to look underneath. We weren't able to visualize the skin underneath until a day later, and at that point we discovered that the patient had a stage 2 pressure injury. And in this particular case, we came to find that even Zeroform, a commonly used dressing, wouldn't necessarily prevent pressure injury development. So this slide basically shows a summary of our patient trial. This table can also be found in the Pearls for Practice in the November 2020 issue of Wound Management and Prevention. So if you want to spend a little bit more time looking at this, it's available on another platform. There were a few patients that didn't have the hydroconductive dressing placed at the time of surgery for one of 3 reasons. One, the surgeon who placed the tracheostomy wasn't one who normally performs them, and therefore had a lack of knowledge of the new trial dressing. 2, it was an emergent tracheostomy surgery in the middle of the night. Or 3, the tracheostomy was placed at an outside facility. All other patients were observed to have dry and intact skin underneath the hydroconductive dressing, no matter how saturated the dressing was. And essentially, we were able to prevent the whole cycle of pressure injury development with this new protocol. And through close monitoring, a protocol was developed to help nurses and respiratory therapists best manage the tracheostomy. During the trial, all but 1 patient received their first dressing change within the first 2 to 3 days post-operatively, and then it followed 1 to 2 times per week after that. And only 2 patients required more frequent dressing changes due to the volume of secretions. To date, we have not had any device-related pressure injuries related to tracheostomies since we made Draw-Tex tracheostomy and tube dressing part of our tracheostomy management protocol. So this was a handout that we created for our staff after we decided to use Draw-Tex for all of our new tracheostomy patients. And essentially, this was a tool that was created to show clinicians how to determine the right time to change the dressing. One of the things that the respiratory therapist said to us was, can you create something so that when we teach the next person, what this dressing is all about, we can tell them, okay, we need to change it every 2 days, every 3 days. And what we found with this whole protocol development was that we couldn't actually set a time of frequency change. We had to teach clinicians how to assess the dressing itself and base their dressing changes on what it is that they observed. It took a little education on our part to, tell the patient, families, respiratory therapists, and nurses that while the dressing would look ugly, you pick the dressing up, look underneath, and that skin looked completely intact. This was a very different picture that everybody has had in years past. Our prior practice, we had a lot of goopy secretions, redness, many, many wounds, and in this period of time, we haven't seen any. And this was definitely a key to helping our protocol become a success. We also created a dressing application for tracheostomy tool. This particular piece shows our surgeons and our nurses how to cut into the dressing so that it would fit securely around the tracheostomy. The photo of the backside of the dressing on the left actually shows the 2 cuts that our surgeons now do in the OR to accommodate the sutures that they're about to place. And then for those, once we've removed those sutures, on the right you can see that we've just enlarged that cut. And at first we thought this was going to be a major setback and a pushback from clinicians, from the nurses, especially respiratory therapists. But I think when they started to see how this improved patient outcomes, those extra little snips really didn't become an issue. So as we wrapped up the trial of Draw-Tex, we were pleased to see that we found a highly effective method of managing tracheostomies by keeping the skin around the tracheostomies clean, dry, and intact. It definitely did address the unavoidable condition of moisture that typically places a patient at risk for pressure injury development. And we managed to end our trial well into the COVID-19 pandemic. And COVID-19 has challenged our patient population. Dressing change frequencies for wound care are definitely being limited to minimize unnecessary exposure of staff to patients, and especially for those frontline staff who are at higher risk for being exposed to COVID-19 during aerosolization procedures such as tracheostomy care. Draw-Tex tracheostomy and tube dressing has actually come to us at a very, very good time. We had basically gone from needing to perform dressing changes every 2 to 6 hours to about 2 to 3 times per week for the majority of our cases. Draw-Tex has freed up more time for our clinicians to provide more important life-saving tasks, and that is success. Thank you.
Daphne, thank you so much for that presentation. We are now going to begin our Q&A session, and joining us for this Q&A session is Dr. Debashish Chakravarthy, the Vice President of Medical Affairs for Ergo Medical. If you have a question for Daphne or Dr. Chakravarthy related to today's program, Draw-Tex tracheostomy and tube dressings, or Ergo Medical, please submit your question using the Q&A app found on your console. We'll try to get through as many questions as we can in the next few minutes. For our first question, Daphne, if sutures are stitched down tightly, how do I get the Draw-Tex around it? Can I cut it?
Yes. So we kind of played around with it. We took note of where all the sutures are for our tracheostomies. And what we decided was that having 2 cuts on either side of the manufacturer's cut would be the optimal space. And so getting it around and under the tracheostomy, we just took a pair of forceps and just led the dressing underneath with the help of respiratory therapists to secure the tracheostomy while we did this. And we are very excited that we really have no troubles getting that tracheostomy dressing underneath the device.
Great, thank you. Now this one has come up a couple of times. How does it work on thick mucus secretions, and how do the secretions not stay on the skin?
That's a great question, and that was definitely something that I was looking forward to challenging during this trial. What we actually found was that the secretions vertically wicked to the top. This is the property of the dressing itself. And so what we found was that we would actually see sometimes a pooling of secretions depending on how much the patient produced, but the secretions would always just float to the top of the dressing. It wouldn't sit underneath. And every time we would walk into a room of somebody who had a lot of secretions, we'd always really want to get a peek underneath that dressing to see what we would find. And miraculously, the dressing, or not miraculously, it pulled that secretion, the thick secretions up to the top, to the point that sometimes we would actually have to take a suction to pull it all off. But nonetheless, the dressing does what it's supposed to do. The drainage just stays on the top.
Great, thank you so much. Now, before our next question, I would like to invite our audience to please take a moment to complete our quick poll, which should display on your screen here momentarily to help us find out how many have joined us for today's session. The question is, how many people in addition to yourself are watching the webinar with you today? If you are attending this webinar by yourself, simply enter a 0. If you are in an in-service setting, an estimate is fine, and we thank you for your response. Now, while our audience is answering that question, Daphne, I've seen this one come through several times now as well. How do I know when to change the dressing?
That's a great question as well. At this point, we have figured out within our own facility what works for us. But the primary education that I provide anybody who's coming into contact with DrawTex the first time is to really assess the dressing itself. After all, we are trying to individualize care wherever we can. And in this particular case, every single patient produces their own volume of secretions. Some people produce none at all, and others will drain copiously. And so our rule of thumb is, 50 to 75% of drainage, you can go ahead and change that dressing. But we have actually found that there are some cases that you could saturate that dressing up to 80% or more and have no problems. Here at our facility, we are finding that our patients generally have about 80% saturation by 3 to 4 days. And so our protocol here within our facility is to change the dressing 1 to 2 days post-operatively, and then twice a week after that. Within a couple of weeks, we find that our patients can actually go to a once-a-week dressing change, but that's what we have found to work for us, and our surgeons have also agreed with that protocol.
Great, thank you. We have time for just a couple of more questions. Have you seen any improvement in your facility's medical device-related pressure injury occurrences now that you've started using DrawTex?
Our facility-acquired device-related pressure injuries, as it relates to tracheostomies, have gone to 0. We have now been with this dressing for well over a year. We started pre-pandemic, and amazingly enough, with the volume of tracheostomies that we have now with COVID-19, we have not seen any pressure injuries related to tracheostomies.
Great, thank you. And what are the other nurses in your facility saying about DrawTex?
Our nurses are very excited. I have to tell you, they were skeptical at the beginning, and it's definitely a scary endeavor when you're looking at a dressing that looks saturated. You take that opportunity to educate your staff. And every time we would walk a nurse over to the patient and say, okay, we understand that the dressing does not look good, but let's take a look at what the patient is experiencing. And we would lift that dressing up, and you can take a look at the skin underneath, and it puts the nurses at ease knowing that the patient is safe and that the patient is actually benefiting greatly from this dressing. So the nurses, I think, all in all, have been very pleased, and they're very excited about the dressing. Our respiratory therapists absolutely love the dressing. It is a far departure from what we had seen in the past, and so it was a very welcome change, and our facility has grasped this, and they're holding it tight.
Great, thank you for sharing. Now, Daphne, before we end today's program, do you have any final thoughts for our audience today?
Oh yes, I think that DrawTex for us has been a game changer. It has been a great solution to our pressure injury woes. Tracheostomies inevitably are a very difficult challenge. It is a life-saving device, and it needs to be there. And, you know, when we're faced with conditions that we can't control, the one thing we can control is the dressing underneath that dressing. And so making that switch for us has definitely changed our practice and has improved outcomes for us. And I hope that everyone has the opportunity to reach out to your ergo medical rep and give this dressing a try. You will be amazed at the results that you see.
Thank you, Daphne. And for those of you who do wish to contact an ergo medical representative, there is a box below your slide view. You can click on the link in there to fill out a form to have a representative contact you. And that is all the time we have for today's program. Thank you all for your questions. If your question was not answered today, an ergo medical representative will reach out to follow up. This webinar has been recorded and will be made available in full on demand after the program. Please look for our follow-up email that will alert you when the on-demand recording is available so that you can review any material you missed or simply go over the program again. You will be redirected momentarily to a brief survey, and as I mentioned, if you would like to speak with an ergo representative, please click on the link in that box below your slide view. I would like to extend a warm thank you to Ergo Medical for sponsoring today's program. On behalf of today's presenter, Daphne Hodges, as well as the teams at WoundSource and Ergo Medical, thank you for joining us and for taking the time to view this webinar. Have a wonderful day.